pleased to talk to you all today about telehealth and how it's become a central figure in the healthcare industry now.
Excellent. And just a quick background on myself. My name is Harsh Parikh. I'm a senior associate at Nixon Peabody. I'm a double Bruin, so go Bruins. Got my undergrad degree as well as my law school degree at UCLA. And I have over 9 years of experience advising managed care organizations, hospital systems, physician groups, physicians, labs, pharmacy, and medical device manufacturers of all shapes and sizes. A quick disclaimer before we move forward. The opinions presented today by myself as well as the panelists are our own, unless noted otherwise. And what we say on this webinar is for general guidance, not clinical advice or legal guidance. So with that, let's sort of take a step back and talk about what we mean when we say the word telehealth. The term telehealth is used broadly in lots of different contexts and has a lot of different concepts. The term telemedicine and telehealth are often used interchangeably. Historically, telemedicine would be when there are two physicians or clinicians on both sides, while telehealth, it would be more direct electronic patient to provider communications. But let me pause here and see if any of the panelists want to talk about sort of historically how the term telehealth has been used.
Well, I'd be glad to jump in. I mean, I found it very interesting during this pandemic to learn how long telehealth has been around. Looking back to find that even in 1879, the Lancet, which is a various famous medical journal, there's an article discussing using the telephone even then to reduce unnecessary office visits. And then in the 20s, there was a magazine called Science and Invention, and it showed a doctor diagnosing a patient by radio. And it even envisioned a device at that time that would allow for a video examination of a patient over distance. And then it was actually during the Mercury space program where NASA began, and you'll probably read about this all the time, performing physiologic monitoring over a distance and using home monitoring. And then really kind of as it gets toward the clinical setting, NASA, further developed this technology with the Papago Indians. There was a project where really trying to reach patients in rural areas and provide care. So, it's been in discussion and for a really long time. So it's interesting to know where it started and where we're coming from.
And I might just add to that to think about, we think of this almost like a science fiction concept, that it's telehealth and that it's really remote, meaning it's got to be international care or rural care. And yet we've seen during the experience with Ebola and more recently during the pandemic, a lot of advances in understanding how you can deliver safe care, even in a patient care room, from a team-based approach to protect the safety of staff and yet really deliver the highest quality of care.
And I'll add on to what Dr. Murthy said about the conceptions around telehealth. And when we talk, Dr. Glaser mentioned that it's been around for a long time and it's evolved significantly over the years. But let's talk about what time period we're looking at. We're not looking at a period of decades. We're looking at a period of slightly over 10 years. If you look back in 2007, 2008, when we first started seeing telehealth models crop out, it's night and day compared to where things are now. Telehealth at the time, this is getting back to, I was in the late 2000s, I was in the hospital at the time. We viewed it as a fancy new technology, a fun toy maybe, something that could potentially augment care, but certainly by no means could it compete with in-person care. There was very low physician adoption exactly for that reason. There was significant concern about being able to provide adequate standard of care to patients via telehealth. And so we saw very limited adoption. You would see the occasional early stage or startup company that would form a teleradiology or tele-ICU business model and gain some traction out of that as a service to augment care, or more specifically, to be a replacement service if the facility doesn't have one on site. But that was more or less what it was limited to. And over the course of the last 10 to 12 years now, it's become very different, where now it's a central figure in the industry. And there are certain areas where telehealth is so valuable that we can't live without it.
Absolutely. When we talk about telehealth, one recurring concept that I want to press on and sort of make sure everybody's sort of on the same page is it consists of two things. It's a tool to provide care remotely. In most instances, telehealth is not a distinct type of healthcare service. And when you look at telehealth from a legal perspective, this is an important concept. And then when we look at the development of telehealth policies, there are sort of four buckets we can put them in. First is synchronous, which is live video, two-way interaction between a person, patient, caregiver, or provider, and another provider using audio-visual technology. Second is asynchronous, which is transmission of video or digital images through a secure communication system. So think of taking a picture of a lesion and sending it to your dermatologist. Third is RPM, remote patient monitoring. The interesting thing about RPM is under the new regulatory framework that Medicare has developed over the last few years, RPM is not technically under telehealth. So that's how we've sort of seen some movement in RPM over the last couple of years, but not in other sort of areas with respect to reimbursement. And finally, we see a lot of policy around mHealth, which is using the phone for any of these things. Now, Dr. Glaser is going to tell me that I'm missing one important modality here of telehealth. Dr. Glaser, what am I missing on this sort of framework that I've laid out?
Well, I was thinking about the telephone. Yes. Meaning that, Harsh will be talking a lot about the changes in reimbursement and the expansion of reimbursement. And that has to do with the telephone, which is, and as we get later in the conversation and we talk about equity and access to the telehealth tool, we can't forget that not everyone has access to the video component of a telehealth modality. And so the telephone is still a good old way to connect with someone. And for a lot of people, the only way that actually we can connect.
And that'll come into, and that'll come into something we'll talk about later in this presentation, I'm sure, about how telehealth can come in substantially different modalities and can even be something as simple as a phone call. But regulations and reimbursement haven't always been in line with recognizing how varied telehealth can be. And that's part of the rapid development that we've seen over the last decade.
And what's interesting is the reason why I don't have telephone on here is because the California Medical Board historically took the position that a telephone consult doesn't meet the standard of care, meaning a telehealth visit had to be through a live video synchronous communication. But we've seen development in this area. So before we get to sort of what's happened with the pandemic, let's talk about what has been sort of the limitations and the state of the affairs prior to the pandemic. Kaushik, let's start with you. What have been sort of the roadblocks in terms of wider adoption of telehealth as a tool in healthcare?
Yeah. So, and it's very similar to what Harsh has on the screen right now. In my experience, from a business perspective and from a regulatory perspective, I've seen three major roadblocks in the adoption of telehealth, even pre-pandemic. And one is the reimbursement limitation. As Harsh mentioned earlier on this presentation, telehealth is not a separate form of care. That's certainly an accepted view now. 10 years ago, that wasn't the case. And many times, facilities, physician clinics, physician practices would have difficulty getting reimbursement off of a telehealth consult on the basis that it didn't satisfy the reimbursement criteria. As you can imagine, that significantly drove a lack of adoption in this field. The second is the sheer complexity of regulations in the space. As I mentioned, I'm CEO of a diagnostic company. Part of what we do is we focus on at-home testing using telehealth. And both pre-pandemic and even now post-pandemic, there's a significant level of complexity. Each state has its own telehealth rules and regulations. Harsh spoke to California. If you're a company that takes a national approach, it's not as if there are national standards that exist. You have to focus on 50 states and 50 different types of compliance. There's certainly a significant overlap there, but as a business, it adds a significant layer of complexity and cost to be able to manage and maintain compliance across all state lines. And the third issue is getting physician adoption in particular. That is certainly that is certainly one that has evolved over time. The medical community now has certainly shifted their view compared to where they were a decade ago. And we realize now that there are certain specialties where telehealth can not just augment care, but be a replacement in some instances where there are limitations in access to care. But those are the three primary limitations in my experience that I've seen pre-pandemic in driving adoption and driving the increase in access in telehealth.
Yeah, Dr. Murthy, what has been your experience like pre-pandemic and sort of the use of telehealth to provide care?
I think building on Kaushik's comments, I would say the three things that come to my mind in terms of the experience in healthcare from a clinical perspective and the physician perspective is really the transformation that we've been undergone with the introduction of the EMR, the electronic medical records, probably being the biggest catalyst for change. I think so. Prior to that, certainly that was somewhat challenging and in some cases traumatic, and a big leap forward and a change in the day-to-day workflow and patterns of practice for clinicians. So as we see the adoption increasing, a lot of that is probably more to do with the younger generations and the subsequent classes of medical graduates that have adopted this as part of, that's all they know. So we still have this generational gap, and then so the second is the challenges with the EMR and the catalyst, and the third is really just the understanding of how to harness this tool is another leap. And there's a lot of effort underway with certainly with guidelines and trying to transform, even simplify the ability to manage care through the EMR with decision support and such. But those, again, it's sort of the next challenge. There are the early adopters, then there are those who are, who really, I think, are slower to adopt. And then there are ones who really feel that that's somewhat against the art of medicine. And so trying to shift those, moving towards evidence-based care, I think is the third piece. And then finally, I would just say access and agility with using these tools, it still remains, I think, a big challenge that has to continue to be supported and impacted on. So that's sort of from the clinical side. And, there's other comments, but let me pass it on to Eve to see what she'd have to say.
Well, no, that was so artfully expressed. I mean, I would only add too, there's also just the everyday practicality of how you incorporate, a digital visit into your regular practice day. And that, again, I'm speaking from a health system perspective where I don't have a private office, for example, but, somehow trying to incorporate like which one of my visits is a telehealth visit versus which ones are in an exam room, and trying to optimize those operations is something that's difficult for the operations teams. Who's gonna get the patient ready from a virtual standpoint, versus in the exam room. How do we then optimize the room utilization? Something that seems very, maybe boring, but actually is a big part of, the operations of a health system. So I think that was always pre-pandemic a big concern, right? When there wasn't this big impetus to actually keep everyone safe, and have that motivation. So that was actually, I remember, as we first started building our telehealth infrastructure, a really big part of the reluctance to adopt. And I would also say too, is it a different kind of visit? And we've even seen this as we get towards, during the pandemic is, what's the right kind of visit? What kind of diagnosis lends itself best to, virtual visits? And I'm happy to talk about that more later.
Yeah. And so I think what you're hearing is there was sort of a slow embrace of telehealth over the last decade, right? Dr. Murthy mentioned EHR. Believe it or not, that sort of the program to encourage providers to use electronic health records, that was part of the last recession. That was sort of a stimulus package that was passed as part of the last recession. And so over the last decade, we have really seen a slow expansion and a slow embrace. But what happened? The pandemic hit. So let's sort of talk about what happened with regard to the pandemic. Obviously, it's not so obvious. So let me throw it to the clinicians. Why was it important in the pandemic to not have patients come in to the hospital or not come in to go see their doctors for an in-person visit? Why was that, not the optimal thing to be doing back in March, April, May of last year?
I can start, and clearly one of the key issues was the events of the pandemic and developments rapidly overwhelmed the healthcare system's ability to care for patients and manage, so doing so safely at a time when there was widespread transmission in the community, overwhelming the ICUs in healthcare systems at the same time, with challenges in access to personal protective equipment to deliver safe care. So prioritizing the access to those supplies in the healthcare setting to deliver care for those who really needed the care really became I think the focal point of both between the ICU being overwhelmed and the limited supplies to really make some changes. In California, for example, the governor issued the cancellation of scheduled surgeries for non-essential surgeries, for example. And that certainly was a big shift. And routine care in the outpatient setting was largely impacted because not only to preserve the healthcare worker supplies for safe care, but also because of the unknowns around transmission and the need to limit transmission. And so the safer at home orders to avoid travel and avoid visit kind of also became a part of the conversation about, well, what is essential? How many of the healthcare visits can be managed in other ways without having that in-person visit, kind of transcending some of the common resistance factors to not doing in-person care, and leveraging the physician-patient relationships where there existed for chronic care, but still, obviously applying it everywhere. So I think that was certainly those are two big factors.
Yeah, absolutely. I mean, I think a lot of times we criticize our government for not recognizing me, but here there was sort of concerted effort by state government, federal government, and enforcement agencies to realize that we should encourage the use of telehealth. So what we saw was this multi-pronged approach to really remove the shackles that have been holding virtual care back. So let me spend a couple of minutes to walk everybody sort of through the legal framework that really opened the door for a broader adoption to telehealth. So first, from a federal level, there was a public health emergency declared, and under a law passed by Congress, the CARES Act, the Secretary of Health and Human Services was able to waive certain restrictions for Medicare reimbursement for telehealth. So what's interesting here is the current laws in the books limit when Medicare will pay for telehealth visits. And in order for Medicare to pay for telehealth, certain statutory conditions would need to be satisfied. For example, the patient had to be in a rural area. The interaction had to be in real time using audio-visual communication at the same time. And what the public health emergency allowed the Secretary of HHS to do is sort of remove all of these limitations. From a state government perspective, licensing is always a huge issue. So the typical rule is if you are providing care using telehealth, you have to be licensed in the jurisdiction where the patient is located. Well, a lot of the licensing regulations were relaxed. Kaushik, I'm sure you have a comment on this because you've looked at multi-state licensure rules here.
Exactly. And this was pre-pandemic. One of our companies was in the process of hiring several physicians to take a national approach. We wanted a 50-state approach with a tele-ICU company. And one of the challenges that we saw was that in much the same way I explained about the technical challenges and the complexity of the regulatory compliance across state lines, we also saw that there was a new problem with telehealth, which is the limitations in the speed of physician licensing. Normally in quote unquote traditional or in-person care, it wasn't much of a problem historically because physicians would be licensed in 2, maybe 3 states at most based on where they physically practice. But based on the physician licensure requirements and telehealth requirements that the physician be licensed in the state where the patient resides, there became a need in telehealth to have physicians licensed in all 50 states so that they could adequately serve any patient population no matter where the patients were. As you can imagine, that became a very complex and time-consuming process. And one that on the business side and operation side, as Eve mentioned, it can be extremely cumbersome. If you're a business or if you're a hospital trying to get all your physicians licensed in all these various jurisdictions, You can have significant delays in care. You can have delays in onboarding physicians and clinical staff. That's where we saw one of the issues. One of the changes that came into play was the so-called telehealth compact, and it was specifically addressed to deal with that problem and get physicians licensed rapidly and give them some level of reciprocity across state lines, so there wouldn't be delays in access to care.
Right, and California, not surprisingly, doesn't participate in these compacts. And so on the reimbursement front, in addition to Medicare, which I spoke about earlier, California required the regulators that regulate health plans, made it an essential requirement for all health plans to cover telehealth visits regardless of these restrictions. So there was an unshackling from sort of other payers requirement. Enforcement agencies that have these rules in place that, again, act as roadblocks also went on and provided additional flexibility. For example, it is typically improper for a provider to waive copays. The Office of the Inspector General said you can do that for telehealth. The DEA requires that there be a face-to-face consult before physicians can prescribe controlled substances. The DEA enacted flexibilities to allow telemedicine visits rather than in-person visits. OCR, the Office of Civil Rights of HHS, requires that any software that is used to provide telehealth be HIPAA compliant. Those restrictions were relaxed so that providers could use Skype and FaceTime to see patients. Some more flexibilities. Again, California, Governor Newsom also enacted additional policies and flexibilities similar, again, and this was the case all across the U.S. And so what we saw was this explosion in telehealth starting in March of 2020. So just give you quick numbers. In February of 2020, about 1% of Medicare visits were over telehealth. Within 2 months, in April 2020, 44% of Medicare primary care visits were through telehealth. I'd love to hear from Dr. Glaser and Dr. Murthy about what they saw on the front lines as, you know, we saw this expansion of telehealth. Maybe we'll start with you, Dr. Glaser.
Sure. Yeah, no, we absolutely saw a profound, widespread, very exponential adoption of telephone tools, and then namely video and telephone visits. I mean, we went even from January of 2020 to April 2020, just from 511 visits over the entire month to 66,000 in April. So that was just, you know, from over 4 months. Also, what we really saw, and this speaks to the reluctance to adoption prior, was that we saw this adoption across all of our specialties. So anything from the telemedical screening for COVID, you know, in a primary care setting, to post-surgical wounds, to behavioral health. So we absolutely saw that. And what we also saw was an exceedingly low no-show rate. We're usually at like about 6%. And then thanks to the parity reimbursement, which you were just describing, the relaxed rules to provide the service across state lines, we really actually found that our patient satisfaction was so high because we were really able to reach so many more of our patients.
Yeah, and so go ahead, Dr. Murthy, were you gonna comment on this?
No, I was just going to almost say ditto, for the experience at Cedars-Sinai, and really the exponential increase in not just telephone encounters, but really, I think similar to what's been in the literature about somewhere between 50 and 200 times, that range of increase, it was represented by the numbers that Dr. Glaser just articulated. And importantly, at Cedars-Sinai as well, there had been a lot of effort over the prior couple of years to try to advance the whole digital revolution or transformation to engage patients and building on the patient portals. And so a lot of that, the ground had been laid to some degree, but it was trying to get the agreements on all sides and work out all the bugs. And this just sort of forced the issue and showed how possible it was. And I think that the pandemic and the relaxation and clarification of some of these regulatory hurdles, I think helped to really move the needle and really experience, similar to what Dr. Glaser said, the patient satisfaction and the low absenteeism or no-show rates were pretty remarkable. I think get additional testimonials.
Absolutely. I just want to actually kind of, give a huge hats off to our IT team, who, within the years, right, the decades kind of before, dealing with the reluctance and really trying to push adoption. I mean, thank goodness, right, we had spent the last couple of years building a telehealth infrastructure and program, and that we were able to then really leverage. I mean, and then also I have to say this, I mean, the IT team was also so incredibly responsive. We could then just, pivot and leverage this. I don't know if we really could have had the widespread adoption without our IT infrastructure.
Absolutely, those unsung heroes. We'll skip this FDA piece because it's obviously important, but given the time, let's sort of look ahead, right? And so what I have on the slide are prior HHS administrator and prior HHS secretary and prior CMS administrators basically making the point that they believe that the genie's out of the bottle. So, I'd love to hear from the clinicians again on, how was the adoption sort of easy, and sort of do you think that clinicians on the ground feel more comfortable with the shift of using technology sort of as a more routine part of the care that they provide? Maybe we start with you, Dr. Murthy.
Sure. I think the answer is yes. Although I think there's probably more work to be done. I think the benefits of having gone through this forced kind of adoption has been paving the way to demonstrate how feasible it is and building on the physician-patient relationships. I think that I know we're going to talk a little bit later about potential opportunities and gaps. I'll hold on some of that. But to answer your question specifically, I do think that needle has been moved. I do agree with that term, the genie's out of the bottle. There's just no possibility of backsliding here, and there should not be. And the critical pieces I think we need to focus on going forward is how do you improve that access, and how can we do this safely, beyond the pandemic. And I know we skipped the FDA slide, but I'll just make a point that, as of today in the US, I think we're in phase 2, and we're seeing in the US now we're seeing at least 2 million doses of vaccine being delivered every day. And as of today, the most recent news is 92 million doses have been administered in the US and 10 million in California. So it's accelerating. And I think our timeline for being able to figure this out so that we're really rapidly moving to adopt these advances that have been made and put the infrastructure in place to build on it it's just sort of more of a I think an imperative at the moment.
Dr. Glazer, did you have any comments on sort of being more comfortable around technology, and whether, does your team feel that they're more, that telehealth is more integral part of their healthcare practice?
Yeah, absolutely. I think now it's just really considered to be part of the, quotidian practice of medicine, at least at a large health system. And I would agree, yes, with the genie out of the bottle statement. I think all of us agree we don't expect nor want to go back per se. And especially as we're seeing our patients safely and appropriately returning to our clinics, our surgery centers, our operating rooms. Really, it's the thoughtfulness about how to best utilize and leverage the tool in a way that puts the patient at the center, improves patient health and the patient experience. Not necessarily think of it as a substitute for in-person care, but a very vital and a very complementary modality. And I have much more to say in terms of some gaps to look at, but yes, absolutely. I think the comfort level is there.
Yeah, and so I think we're sort of entering into a brave new world now, right? With digital technology and sort of virtual care really being at the center of it. I have on the slides just 2 examples of innovative types of healthcare models that my office was working with during the midst of the pandemic. One is providing traditional hospital services at a patient's home. So the idea really is somebody that needs to be admitted gets admitted in their home, and the hospital arranges to have physicians round the patient at the patient's home and sets up technology at the patient's home to monitor the condition, and the hospital gets paid as if the patient was admitted, in one of the beds at the facility. Another type is a virtually guided at-home test. So again, having a proctor administer a test through telecommunications rather than being at a site, at a point of care site with a clinician around. Kaushik, I'm sure you have thoughts on this. I mean, some of this is really accelerating a trend that we were talking about, that we were seeing prior to the pandemic, right? So there was a trend to have digital health be more of an integral part of healthcare services. We're just sort of seeing an acceleration of that, right?
And I feel terrible just to be redundant with what Dr. Murthy and Dr. Glaser said, but it's exactly what they said. It really was a forced adoption. It's not that the demand wasn't there. It's not that the ingredients weren't there for telehealth adoption. It's that the pandemic forced people to take it seriously because there was no alternative. I'll give several examples. I spoke about tele-ICU. I spoke about teleradiology. We saw telepsych in particular. Telepsychiatry has been known for quite a number of years now that it has significant benefits compared to in-person psychiatry. Patients often feel more comfortable. Dr. Glaser talked about patient satisfaction. We've seen that in the telepsych context with both psychiatrists and therapists, that patients often feel more comfortable by telehealth in certain instances for certain situations. That's been known for quite some time now, but we didn't see quite the level of mass adoption. The pandemic forced people to consider it differently. Telepsych has become almost exclusively, psychiatry, I should say, in general, has become almost exclusively telehealth. There are other services, at home. So, the transition to at-home care settings originally it was going from inpatient to outpatient. That was a trend over the last decade. The pandemic forced people to go even further and say, we're going to do things at home, doing blood draws or providing urine samples at home and then shipping it out to a lab or shipping it out to a in-hospital facility, or going to, or the idea of introducing telehealth as a way to increase access to care in remote communities. I know back in my old hospital days, if any of you are out in a rural area or if you've worked in rural health, it is becoming increasingly harder to the point of an impossibility to get specialists to go out to rural communities anymore on a permanent basis. More often than not, we're seeing a hub and spoke system where specialists will reside in an urban area and go out to a rural community for maybe one day of clinic a month or a couple of days a month, something like that. The pandemic forced people to take a hard look and say, there are some specialties where we can actually provide consistent access to care via telehealth. And maybe there is some time to go out and do, to be in person for a specified number of time, but it won't be that patients will have to go weeks or months just to be able to see a specialist. That's one of many ways that the pandemic has forced a change in things. And I know there's a question in the chat about, where telehealth's going to evolve and how we're going to get there, and what new opportunities are going to crop up. And that's actually, and I'll just jump the gun on that now and say that that's actually one area where I think that we're post-pandemic, we're going to see a significant shift in rural health and how rural health is administered, how those patients have access to care, what they need to drive into urban centers to get care at tertiary care or AMCs. I think we're going to see a significant shift there now that, again, to use that analogy, now that the genie's out of the bottle.
Yeah, and so when we sort of talk about the future of healthcare, from a legal perspective, what's old is new again. So the same sorts of issues that you were thinking about when you were providing healthcare services in a regular setting, at a hospital or a clinic, those same sort of issues are still going to be there, right? So corporate practice of medicine is the company you're setting up attempting or claiming that it's providing healthcare services when it shouldn't. What is, scope of practice? Are mid-levels practicing within their defined scope of what they can do? What about the sanctity of a patient-physician relationship? Is that still as sanctimonious when there isn't a pre-existing relationship except for the telehealth consult? What about fraud and abuse? It's really easy in some ways to set up a video consult. It can be real, abusive. Licensure is always an issue. Are you licensed where you're supposed to be? And then FTC. So let me turn back to the clinicians again and sort of ask you, what are the limitations of telehealth? We sort of talked about all the great opportunities, all the ways it's expanding care. But Dr. Glaser, let's start with you. What do you think the limitations are of providing care in a digital environment?
I'll just start with one before I pass on to my colleague. I mean, I would say we really need to deal with equity. We really have to make sure that in this amazing effort to bring care and access and convenience to many patients, that we haven't made it harder for our most at-risk patients to get care. I mean, as excited as I have been, it's also sobering to see, the research to say that among Americans, for example, over 65, who are about 18% of the population, they're about 18% of the population that actually uses the internet, and only around 60% of them are able to send an email, fill out a form, or find a website. And in addition to our older Americans, we also have a lot of at-risk groups who struggle to get online. Among our lowest income Americans, who also make up about an eighth of our population, just 53% are estimated to have digital literacy, low rates of smartphone ownership, broadband access, and internet use. And I don't think we can overlook that. I think of these as opportunities, but we really saw, even in these exponential adoption and the video visits skyrocketing in the early days of COVID, that the proportion of video visits in our patients 65 and older fell. And we also saw this among patients with non-English preferences. So we still have a lot to sort of really figure out when we say there's increased access, and we really have to explore this space and look at alternative video platforms. So that to me is the biggest one. I think there's other ones, I think, honestly not as important, but people have talked about like the website manner, again, really what that is, that the physician, patient rapport that you can achieve on video. I think you can do a lot, but just something that we need to explore, and just, again, making sure that the patient experience is really at the center of, I would say, innovation, operation, and implementation.
And I'll add on to that and actually address the second question in the chat about minority communities that may lack the internet access, or, like you said, Dr. Glaser, that not everyone may have the digital literacy skills that are necessary to participate in telehealth models. I would say, the challenge, of course, is digital literacy is one issue. I would say the other challenge is, and to go in a very different direction, is actually the IT infrastructure. Dr. Glaser talked about how on the facility end, there has to be significant time and resources and infrastructure built out to have a working telehealth system. It may seem as easy. I know in the last year, all of us have gotten used to Zoom or Teams or or WebEx or whatever service we might use, and it's become second nature to us now. But if to use it on a business level, where you're using it consistently and you're able to use it without interruption, it's very easy to take for granted the amount of work that goes on behind the scenes. I mean, case in point, credit to the IT team here at UCLA who's doing, who's helped put on this presentation today. I would say, just to directly answer the question of how do we address that digital divide, we focus on, we have to keep in mind that telehealth doesn't always have to be fancy. We've gotten accustomed now to thinking that telehealth is, video chat or things like that, or something on your smartphone. Telehealth could be as simple as a phone call. And we have to recognize what resources the community has and utilize those resources. If they have some boots on the ground, utilize that in tandem with telehealth. Case in point, I talked about rural healthcare. We know that not all rural communities are going to have certain types of specialists on site. You use telehealth where you can, you augment it with boots on the ground.
Dr. Murthy, with the just last couple of minutes we have, your thoughts on, what are the biggest opportunities and gaps going forward?
Yeah, and so I think the couple of them that we hit, I absolutely agree with the equity issue. I think what we have to keep in mind is that we stepping back a little bit, zooming out, where is healthcare going? And I think a couple of things, themes that resonated that I wanted to bring back from earlier in the discussion. One was around precision health. I think there's an opportunity as we build access to actually drive the not only access, but also the quality of healthcare delivery, to expand access and high quality care to our population, really both in prevention as well as maintenance for chronic diseases and such. That I think that's a promise, I think, of healthcare delivery in this country that I think we should all aspire to. At the same time, I would say a potential, not so much a gap, but an opportunity is also to keep in mind the issue of how do we balance that with, and I know there's other words for it, one extreme is fraud and abuse, but I would also say this concept of low value care. How much are we diffusing or distilling out, diluting the care And I think that's a balance that I think we have to keep in mind as well. I think we need to really think in those aspirational terms of equity and access and adherence and patient relationships and satisfaction, and the provider satisfaction too, because ultimately, as you provide better care and access, it's going to be more rewarding. I think those are some of the things I would feel: access, equity, precision health is really, I think, exciting, and to be able to harness these tools to get to that promise in this country for that. Things that have been accelerated by the pandemic that we should be able to realize.
Excellent. Dr. Glaser, I'll give you the last word. I think Dina's here, so I think she's trying to tell us we're done. But
I'll hand it over to Dina. No, I couldn't agree more.
And thank you all so much. This was an amazingly full analysis and discussion of this topic. And Harsh, I couldn't have imagined anything better. So thank you so much, doctors. Kaushik, thank you for your expertise and your words of wisdom. And it's actually very inspiring to me as well.